we're just so grateful that you could join us tonight. And this is really an exciting sort of silver cloud. I know many of us are not where we expected to be in the world these days, and it's nice to sort of have this technology that allows us to come together and reaffirm our friendships and our partnership and our commitment to our Kenyan partners as well. So I'm, for those of you who don't know me, I'm Adrian Gardner. I'm an infectious disease physician, but as of February, the director for the Center for Global Health and the executive director for the Ampath Consortium. And for the last 7 or 8 years, I was the executive field director in Kenya. So I've just as of earlier this year, I've returned to Indianapolis, and now living in Indianapolis. So, and I'm coming to you tonight from my office, formerly Bob Einhorst's office, since I'm on service right now. So I've actually been, it's been a long day. But I had my 7-year-old daughter, Adeline, make me a little Fireside Chat here, the rendition of the Fireside Chat. Adeline has been one of, Adeline grew up in Eldoret, and so she's really, when she heard I was hosting a Fireside Chat, she thought she would make a little picture here, and it's been an important part of her life, frankly, to see the Fireside Chats every night. The last few years, they've been right outside our home, and sometimes outside, sometimes inside, depending on the rain plan. But anyway, so again, we're thrilled to have so many of you former trainees and supporters, and lots of people from many years ago and some from more recent. So this is a great opportunity just to bring everybody back together. Wow, someone from 36 years ago, I can see on the chat. Welcome. So we're lucky to have with us tonight Dr. Caitrin Kelly, who's been our medicine team leader for a year there on the ground. And she's, well, I'll let her introduce herself where she is right now. And of course, as many of you know, and needs really no introduction, Joe Mamlin, our co-founder of this program, and really heart and soul to this day. So they're going to be presenting some work from the Busia County HIV care and universal health cover effort that we are continuing to support, even if remotely for now. And as Deb said, we hope that you will all participate. We'd like you to remain on mute, so just so we don't interrupt things, but please enter questions or comments in the chat, and we'll have an opportunity to sort of go through some of those comments and questions towards the end here. So let me, before we turn over to the programming, let me just allow Caitrin and Joe to introduce themselves and tell us sort of where you are right now and where you expect it to be.
Okay, sure, I'll go first. So I'm actually in Colorado right now. I did not expect to be right now. After we all left Eldoret because of coronavirus rather abruptly, Eldoret is my home now, and I didn't have a true home in the United States. So I've been staying with very good friends in the Indianapolis area who are actually both Empath medical student graduates back from 2011. So it's been fun because they know actually a lot of you and a lot of the IU House staff. So that's been great. And then last Friday, my parents were driving out to Colorado. So I jumped in their car and am reporting from actually a neighbor's house because our internet is not good up the mountain. So that's where I am.
Well, I'm Joe Mamlin. My head is in Indianapolis. My heart is in Kenya. And my arm is around many of the people I see on this camera right now. But anyhow, we look forward to chatting with you.
Good. So I don't have too much more to say. I think we should just let you guys get at it. So, right. Caitrin and Joe, I don't know who's starting, but
I'll go first, then toss. Okay. First of all, everybody nestle up close to the fire, if you will, and enjoy the Fireside Chat. And if I could, I'm going to call for a slide. Technically, Deb been nice enough to pop them up when I need one. But Deb, let's put that first one up. Okay, there. I'm sure everyone's familiar with this, but I just wanted to remind people we're going to talk about Busia. And you can see Busia is, the dark blue represents the catchment area now of Ampath. You can see multiple counties. And Busia is a small county, but it's a most western of our sites. And it's bordering Uganda and Lake Victoria. And that's most of our conversations going to be about Busia. Yeah, that's fine. You can turn the slide off now. I tried to think back when I first hear about Busia. We were busy putting together the first clinics in the early 2000s around Eldoret, Masoriot, Turbo, and Burnt Forest. And I heard someone tell me about a place called Busia, and that World Food Program was bringing big trucks and delivering food to people that were with AIDS. There were no treatment programs, but they were bringing food to them. So, gee, that's interesting. So I got with that friend, and we got one of the Ampath drivers, and we went out there. What's not hardly called Ampath at that time. And sure enough, on a big field in Batula, Caitrin, that's around the Hunyangu area, there was a big kind of soccer field, and a big truck was putting out food, and people were queuing up nicely to get the food. And I looked at that and realized here were people getting food, but dying for lack of antiretroviral drugs. And back around Eldoret, we were given antiretroviral drugs, but people were dying for lack of food. And you kind of wondered, Busia began to get me thinking, what's wrong with this picture? And so we decided we might need to change things a little bit. So let's put up the next slide, if you would. Some of you may remember these, but we basically ended up building these high production farms. For those in recent years not seen these, they're quite beautiful. This is continuous irrigation, which means it's drip irrigation at all across the farm, so you can produce 12 months a year. We built 4 of these, and this one was funded by the Buffett family. And we therefore had a lot of fresh produce, and then joined with World Food Program. They give us their food basket to put with it. And suddenly, before we knew it, we had the largest medical feeding program in the world. We were feeding over 30,000 people every day. But that, just to give you that connection to Busia and our food program. You can turn the slide off now. Now, as I indicated, Busia had no one responding to that remote little county. And MSF responded. So Doctors Without Borders moved into Busia and started setting up clinics and providing care for the first time, which was just wonderful. As we were growing Empath ourselves, they were growing their services across Busia. But as you know, MSF is for emergencies. Excuse me. And they don't tend to stay in a place for long periods of time. And as you know, HIV is not something that goes away easily. And so their time commitment got longer and longer. So they spoke to USAID in Nairobi. They contacted Professor Kamayo and asked, could Ampath help? And so he asked if I would lead a team to go out to Busia and take over from MSF in the Busia County Hospital at a place called Amakura. And so we started there, and we handed over from MSF. And before long, MSF got back to USAID, they got back to Kamayo. And so next thing you knew, we took over Nambale, and then we took over Hunyangu, Matayos, Bumala A, Bumala B. You get the picture. And then finally, we were moving along, and then they said to Kamayo, we're in a very remote place. No one will go, and no one will take it over, and we need to leave there. It's a place called Port Victoria and Mukabola. And Kamayo says, we'll take that over. Joe, go back down there, start 2 more clinics. And that's how we really got started, was basically taking over for MSF. Let me put up the next slide, if you would. Like all the government clinics, wherever we went, there's no facility or space in which to see high volumes of patients. So this, Caitrin, you might not know, this is how we started in Port Victoria. We just put up tents. Let's go to the next slide. And you can see inside is really quite nice. And the next one. And you can see we had enough room where we could see a patient. And the next one. Next slide. Well, we got to where we moved beyond tents. We built these things. Might not be apparent to you just glancing at it. That's Professor Kamau coming for the dedication. And those two white structures on each side of the door he's going to are actually truck containers. So we got the idea of using truck containers in parallel. There are two of them there, separated to create a hallway between them as a waiting bay. Then we cut 4 rooms into the side of the container inside. We could make 4 rooms and then put a thatch roof over it. And suddenly we had a 8-room clinic. And we did this across Busia. Let's see the next one. This is a similar thing, that now the containers you see on both sides of these 2 clinical officers, those again, truck containers with a central area for a waiting bay. That's down in Mukabola. And the next slide. You can see the space inside. This is Jackson, one of our fine clinical officers. But there's no room to really put an examination couch or do very much. But then we ran into a problem, and Jackson was one of the first to let us know about it. Let's take the next slide. You see his lower lip. The bees love to come to these containers, and they're really just glorified beehives. And dangerous for the patients, as you can see, dangerous for our providers, as you see what happened to his lower lip this day. I couldn't believe that he could generate a smile with a lip like that, but that's the kind of staff we have. So let's go to the next slide. So we met our promise to them to get them out of the containers as we progressed along. And we just moved into this beautiful building now in Mukabola. And we built buildings 2 or 3 times that size at Port Victoria and Busia County Hospital. Those are much larger areas. Okay, you can turn that slide off. Then about 6 years ago, Kamau, kind of in his tendency to kind of organize things a little better, he approached me and asked, would I be willing to be the Ampath patron for Busia? What he means by that is I would be the consultant to look over the county and be kind of a first contact and visitor to the multiple clinics we had in Busia. And I told him, sure, I'll be glad to do that. And so, you know, I've had a lot of titles during my life. I was a chairman in Afghanistan. And in IU, I got to be a division chief and a chief of medicine. Even got to be the president and CEO of the university's initial movement toward a university practice. I even got to be an executive field director like Adrian when I was in Kenya. But when I look back, I may be proudest of being called the Empath patron for Busia. But anyhow, it's a most remarkable place. And I'm going to just finish with a few remarkable things about it. Of course, at first, let's go to the next slide, is a wonderful staff. Next slide, please. I know Caitrin can identify with this. As you look at the wonderful group we have at each one of these clinics, and they're all very similar to what you see here. This is from Matthias, but it's got clinical officers, nurses, social workers, nutritionists, outreach workers. A number of them are our former patients that are now working as outreach workers or as peer educators. But working as a team, you find you can just take on anything. And one of the most inspiring parts of being a part of Busia was being a part of these wonderful teams that stay on site there day after day in a very remote part of Kenya. We can turn that slide off now. It was no surprise to me that as the years went by, the government, USAID and PEPFAR, they began judging all the counties of Kenya to see how they were doing in terms of their ability to find everyone, get them on drugs, and drop their viral loads, and to find that at the very top in the country was Busia. Not a real surprise to me. Certainly a leader among Ampath. I'm just very, very proud of them. Another thing that's remarkable to me is, let's go to the next slide. It's kind of the remarkable people of Kenya. Now these, I'm going to talk about the people, but these clinical officers, when you go out there, they're going to show you something and ask for help. But you just hardly get in the office, as Adrian knows, they'll pop up a leg like this and say, okay, Prof, what are you going to do with this? Let me go to the next slide. And sometimes the malignancy is in the mouth. As you can see, if you're in the middle of nowhere and you're presented with someone who walks in asking for help and they've saved this woman for me to see, and I'm sure Caitrin can remember these experiences as well. But let me show you the next slide. This is the same woman a year later. And this is because we're not alone there. We're tied in to Moore University, Moore Teaching Referral Hospital, and the Consortium, bring in oncology treatment and tertiary care. And we can take something as difficult as that out in the village and end up with this kind of outcome by being tied to a complete system. Let's see the next one. This is just an example of a little baby held by Regina. Regina is one of our initial nurses, holding a little baby girl who we just got the result back on her HIV testing. We're always so intent on preventing mother-to-child transmission. And Regina is running in the room to let me know this child's test is negative. And then if you look closely at the chart, the child's name is Michelle Obama. And I think you can see the connection between Kenya and that time back in that time just after the Obamas came into office. And here was a little girl. I'm sure there are many, many little girls across Kenya named Michelle Obama. But this was our first one in Ampath who had a nice negative test. Let me see the next one. I decided to see if I could find Michelle a few years ago. Here she is now with her parents. Of course, both of them have HIV, but you can see the humble situation. They have almost nothing. You see there are no shoes, very tattered little dress, and then you can turn that off now. But the thing that came to our mind is I learned from Busia, it's one thing to get excited about stopping transmission from mother to child, and you feel like you can just spike the ball in the end zone and you're done. But Michelle reminds us the struggle's a longer one than just getting through that transmission. She's at risk of other problems as years go by if she doesn't get educated and doesn't have some way forward. And of course, we're going to stick with Michelle specifically now that we found her and make sure she gets all the way through high school. But members of the Kenyan staff have now taken this and begin to look at a lot of our children who've been through mother-to-child transmission successfully, but now checking on where are they now and what kind of programs should we be thinking about to make sure we don't abandon these at-risk children just because we got in good shape at 18 months of age. It's a bigger problem than that. Okay, let's go to the next slide if we could. Another thing that's kind of remarkable is the trips going out there. You know, when you, it's a long trip. I get up at 4 and fix lunch for myself and the driver. Not too many other places to eat out there in spite of this sign. but you're going to spend 6 hours in a car. So I like to look out the window while I travel. I enjoyed that. I always enjoyed this sign. So you'll see the fun of it, Tortoise Hotel, and they use that name, but it's going to be specialized in fast foods. And just to make it even more of an ironic twist, they say coming soon. Anyhow, next one. Next slide, please. Yeah. And here you are. The car has to stop because look at all these kids. These are little boys, each with a little headgear with this flared straw thatch thing on top. These are boys coming out of the bush where if they've been for several weeks as part of their circumcision rites and coming of age within the tribe. As they come out, now they've been circumcised, they take over the highway and you just stop and let this celebration go by because everyone is proud of these young boys. Next slide. You know, if you've had a hard day, it's good to see something like this. Plan B Pub. I just kind of like the looks of that. The next one. Now, I haven't eaten there yet, but I just felt like they used my name and I just felt like I should eat there. But I haven't. That's Joe's Lounge. That's on the way. The next one. Now, I like this one. You have to look closely, but that's a little one-room church. But just under the name Deliverance Church Ganga is this wonderful phrase, the church of choice. Can you imagine having a little one-room church in the middle of nowhere and then underneath it put the byline, the church of choice? I just thought that was nice. Let's see the next one. And my favorite, Stima in Swahili means electricity, but there's a little electrical shop, and this is literally at the end of the earth, but look what he's written there, living in the shadow of timeless elegance. I couldn't do any better than that. It tells me so much about the people of Busia, and you can't help but fall in love with them. Okay, let's turn them off. Another remarkable thing, of course, is things grew beyond HIV. Suddenly, our reproductive health team and our pediatricians came in and created wonderful programs for pregnant women and postpartum women and for children. And then we ended up getting a large World Bank grant, and we have wonderful programs emerging in chronic disease, cancer detection, looking for hypertension. I see Ed Feinberg's in here, I have to emphasize that, and diabetes, and but mental health problems and so forth. And at the same time, we were able to get a real expansion of our income generating activity, really took off in Busia. And of course, our wonderful linkage of all of it to Moy Teaching Referral Hospital and the Moy University staff. And the final, almost the final, the remarkable other thing is the future. Look at what you have. You've got a wonderful population of people, clinics everywhere with wonderful staff that's expanded now to chronic disease, maternal child health, income generation. We have a wonderful working relationship with the Ministry of Health and the government in Busia. And you realize you've got all the makings there of creating a program of true population health and universal insurance for these poor people. And the final remarkable thing I want to say is the remarkable future in front of us now, because we have new leadership. So let me introduce you now to the new Ampath patron for Busia, Caitrin Kelly. It's all yours, Caitrin.
Wow, Joe, I didn't know I had the patron title for Busia until now.
Yeah, you got it.
Before I start, can you guys hear me okay? My headset decided to go out while Joe was talking, so I just want to make sure. Okay, the volume's okay, great. So it's so nice to see so many familiar and very missed faces out there. Thanks for having your video on. I miss you guys. So to start, I just wanted to go back a little bit to my first day with Empath, which was about a year ago when I started as medicine team leader. And I did a couple days of orientation in Indianapolis to meet the whole Indianapolis team. And that's where I met Joe Mamlin for the first time, who called me into his office. And after a little bit of small talk, immediately started telling me about Busia and the patients and the clinical officers that he loves there. And at the end of a lot of stories and him kind of telling me about his work there, he said, Caitrin, will you consider continuing to go out to Busia? And I don't know if you could tell from the map, but as Joe mentioned, it's a 3-hour drive to get there. And Joe Mamlin is a morning person, and I am not a morning person. He wakes up at 4 in the morning every day anyway. I do not. So I kind of thought about it, and I thought, well, I better try this out and see what it's like. And Joe has set this precedent of leaving at 6 in the morning sharp and packing a picnic for everyone on the trip. So I found myself waking up before the crack of dawn every Tuesday and packing a picnic for a car full of people, usually our med students and the driver. It involves a lot of sandwiches, and doing the trip out there. And it is exhausting to do that 6 hours in the car. Luckily, someone else drives because we would all never make it back if I were the one driving. But it has been the highlight of every week where I've been an elder because I've gotten to know the clinical officers and the patients out in Busia and really experienced the challenges of providing care to very complex medical and social situations and understanding what it's like to work in the healthcare system outside of our big city tertiary referral hospital. So I'm so grateful that Joe gave me the introduction to Busia and that I was able prior to COVID to go out there every week and hope to be back soon. So I think Joe has given you a lot of good history of how the Busia Empath relationship started. So I want to switch gears a little bit and talk about the future directions that we hope to go with our Empath relationship in Busia County. And this is important for a number of reasons, but one of them is, as you may or may not know, that the US government and PEPFAR, USAID are cutting funding to HIV programs across the world. And one of the challenges we face is how do we sustain the wins we've made in HIV care across the world, and how do we sustain quality care? And also, how do we apply what we've learned from HIV care to primary care and chronic disease care in the health system? So that is sort of the background of this initiative that we have for Busia County. So before I actually start to talk about the specifics, I want to tell you all a little bit more about the Empath population health model. You may or may not be familiar with this, but Empath population health is our community-based care program that really focuses on the social determinants of health. And what we know from being physicians and taking care of patients, and also from years and years of research that shows this, is that you can't care for patients. It doesn't matter what medical intervention or treatment you have. If patients don't have access to basic things like food, stable housing, a reliable income, education, health insurance, and those sort of things. So it doesn't matter what we do as doctors if those things aren't there supporting the patients along with the treatment we give. So the Empath population health model really focuses on these social determinants of health. And we do this through a 3-pillar approach. And Deb, if you don't mind showing my one slide of the 3 pillars, because I'm putting this up for you because when I first started at population health, I could never remember what people were talking about. They were always talking about pillar 1 and pillar 3, and I had no idea what was happening. So I put it all here for you as I talk. And Joe, you'll notice I put a little B up there, representative of our Busia clinics that where clinic hours are determined by the bee activity. And we have to end clinic early when the bees get angry in the hotness of the afternoon. But so population health has 3 pillars that address the social determinants of health. And I'll just quickly go through them and then I'll tell you more about them in more detail. But pillar 1 is community economic empowerment. Pillar 2 is health system strengthening. And pillar 3 is expansion of insurance enrollment. So in Busia County, our goal is to make universal health coverage a reality. And what do we mean by universal health coverage? So this is a term that is used widely and endorsed by the World Health Organization. It includes three components of health. One is that everyone has access to health regardless of your income. Two is that the quality of healthcare you're accessing is good, that it's not just having a clinic or a building or a structure, but that people can actually go there and receive the care they need. And the third component is that receiving that care doesn't cause financial hardship or financial ruin. And so the WHO actually started advocating primary healthcare for all back in 1978, but in recent years has sort of made a new push to focus on this. And I want to take a brief aside to just bring something else to your attention that's related, because I brought up the World Health Organization. As you may or may not know, with everything going on in the craziness of the world right now, the current Trump administration has requested that the United States withdraw support and participation in the World Health Organization. And many people aren't familiar with the work the World Health Organization does. It's kind of back there, a name you hear. But in Ampath, we've worked closely with the World Health Organization over many years. They've collaborated with us on research, on many programs. They provide technical assistance and guidance to the government of Kenya and to our programs, and we provide them with research to inform those guidelines. And the World Health Organization does a lot for programs like ours, and for programs all over the world for both communicable and non-communicable disease, and really protects the most vulnerable in the world from all sorts of things. And so I just wanted to take a moment to ask you to consider advocating against this move to withdraw from the World Health Organization, because it's not too late. We have about a year before this will come official, and you have the ability to reach out to your local representatives by phone, email, letters, whatever it takes, to take a stand against this, because it's detrimental to the work our program believes in and to the health and safety of Americans and the whole world. All right, so that's my little tangent. And I'm supposed to say those are my personal beliefs and not necessarily endorsed by Indiana University. But there it is. So now to come back to our regularly scheduled program, back to universal health coverage. So in Busia County and Bunyala sub-county in particularly, we are trying to see how we can make universal health coverage a reality. And how we're doing that is by applying the population health model and taking lessons learned from 10 years of experience of population health programs, and taking lessons learned from those 10 years of experience and trying to apply it in a new way in Busia County. So I'll go back to those three pillars I mentioned and tell you exactly what we're doing with those three pillars in Busia County. So I'm going to start with pillar 3. And to remind you, pillar 3 is the focus on expanding enrollment in the National Health Insurance Fund. So in Kenya, nationally, about 20% of people have insurance coverage. But if you look at income level, most of those people are in the highest income level. About 40 to 50% of Kenyans in the highest income bracket have health insurance. But in the lowest income bracket, lowest 25%, only 3% of people have health insurance. And in Busia County, where we work, most people are in that lower income bracket working with subsistence farming and informal labor and do not have health insurance. And why is this important? One, because of healthcare financing. How can a healthcare system sustain care if they don't have money coming in from either insurance or fees? And two, because it's devastating to our patients who get admitted to the hospital, which we see all the time at our National Referral Hospital in Eldoret. They come in after much delayed care with very complex disease and stay in the hospital for weeks, needing oncology treatment, cardiology treatment, specialty care, and they don't have insurance. They sit in the hospital and they rack up a huge bill. The ones that are lucky get the treatment that they need and are discharged, ready to go home. But then they can't pay their bill. And what happens in the public system in Kenya is there's a negotiation process that I don't quite still understand the details of, but it's between the hospital and the patient's family and social work to try to get someone to clear that bill for the patient. And when they can't clear the bill, they just sit in the hospital kind of as prisoners for weeks until someone can help clear that bill. And that can be devastating from just a, exposure standpoint of being in the hospital for unnecessary weeks, but also to patients' families that have to go to extreme ends of selling land and selling animals and foregoing their kids' school fees and things like that to try to cover their hospital bills. So that's sort of the background of why that pillar 3 is so important and one of our goals. So what we've learned from other counties and what the challenges is when our pillar 3 team goes into the community and provides education on the National Health Insurance Fund, people want insurance and they want to sign up, and they do. But then the problem is they default and they drop out of the insurance payments. And why is that? There's a lot of reasons, but 2 main ones. The first one is that they can't afford the payments. So the National Health Insurance Fund has a plan that for $5 a month will cover an entire family for insurance. So it seems very cheap and like a fantastic deal, but for our patients in Bunyala and Busia County, they don't have $5 a month when it comes after school fees for their kids, and they've just used all of the money they have to cover school fees, or when their crop yield is not good and they have to stretch what little money they have from their crops to last the whole year. So they default, they don't pay their insurance, and then they get cut from the insurance scheme. So that happens. And then the second part that happens is that they're paying the insurance and then they go to the public health system and they get there and there's no drugs and they can't get the labs they need. And that's because the health systems are so underfinanced that they can't get the care that they need even when they make it there. And so then they feel like, why am I paying this precious $5 a month to go to a hospital that doesn't have drugs that I need? So we recognize that those are the 2 primary barriers for people enrolling and staying enrolled in insurance. So we're doing something really radical and different in Busia in that we're actually supporting the enrollment of the entire sub-county of 80,000 people in insurance for a year. And Joe and his team have figured out a mechanism to make this sustainable, where the capitation payments from the insurance company go back and repay their fee for the next month. And I know it sounds like it doesn't make sense, and it didn't make sense to me either until Joe explained it with a PowerPoint like 4 times. And I really didn't get it until he got his PowerPoint skills way up and added colored arrows and diagrams. And then it all made sense. So Joe, thank you for thank you for upping your PowerPoint skill level. It really helped. And there's also a lot of math and Excel spreadsheets involved, which I won't go into, but it works, and we're hoping to make it a reality in Bunyala Sub-County to get 80,000 people covered by insurance. And I'll refer questions about that to Joe after the talk. So that's pillar 3. So now I'm going to talk about pillar 2, which is health system strengthening. So for those of you who've worked in Kenya, you know that there are many, many challenges to providing care in Kenya. I'll mention just a few. So one, as I said before, is financing. There's just not enough money in the system to provide the quality of care that people need. And that's multifaceted, but main reasons are that 1, the population it's serving just doesn't have a lot of money. And 2, it's primarily a fee-for-service model where people can't pay the fees. So it's very, very challenging for the health facilities to maintain drugs and supplies and that sort of thing when they don't have a consistent flow of money coming in. And to give you an example of how dire the situation is, I'll take a minute to just tell you a story. And this is a pretty long story, but I'll tell just the end part where Joe and I were actually in the car together coming back from a meeting with Busia County leadership. And I got a phone call from an unknown number, and I answer it, and it's actually the ambulance driver for the Busia County Hospital who had gotten my number from someone else. And he was calling because I had requested that the county hospital take a patient that had been in their ward for months to Living Room Hospice, which is a palliative care center we work closely with Julie Boyd and the team. And this patient was in dire need of palliative care services, had been on the ward for months at this county hospital. And after many discussions with the patient's family and the facility in charge and various people, everyone was in agreement that the county would provide the ambulance and transport him to the hospice center. And I would use some of my Empath humanitarian funds to cover the initial basic fees for his admission there. But what happened, a small budget and such a small amount of money in their account that they calculated exactly how much gas they would need to get the ambulance to the hospice care facility and back. But they miscalculated because Google Maps was off a little bit by where the facility was. And they're on their way back after dropping off the patient, and they're on empty, about to run out of gas. And they'd called the Busia County Hospital and they said, there's literally no money in the account. We can't send you anything. So the ambulance driver called me and said, I'm going to be stuck on the side of the road with our nurse who you know, and we don't know what else to do. Can you please pay some money to the gas station for us? So that's just a little example to tell you, to demonstrate really what I mean by financial challenges. And related to that is financial challenges also lead to drug and pharmacy stockouts and supply challenges, because if you can't continually pay for those products, they're not going to be sent to the facility. So patients are constantly struggling with paying fees to get to the facility, and then they get there and they see the doctor and they're prescribed treatment, and then they go to the pharmacy and they find the pharmacy doesn't have the drug they're prescribed because they're out of stock. And so then the patient is left with struggling to try to find a private pharmacy to get the drug, and they have to find transport to get there, and then the private pharmacy may or may not have that drug. They don't know until they get there. I could go on a while about this. I just mentioned one more. So another major challenge is just healthcare worker shortages. The clinical officers provide a majority of the care in the county facilities, and they're stretched so thin. Every morning they're faced with a very long line of patients waiting to see them. So they have to work very quickly. They are overworked, they are tired, and they are living every day dealing with the frustrations of the health system that I described, and unsafe working conditions. And because of that, they're often burned out, as any of us would be, and it leads to healthcare worker strikes. And healthcare worker strikes are rather common in Kenya and very disruptive to the system and patient care. So those are just a few of the major challenges, but of course, as you imagine, there's many. So the Pillar 2 task of healthcare strengthening is a very complicated, big task to try to accomplish. And so how do you do that? How do you improve healthcare in any system? And because it's an incredibly complex system. And I don't know the answer to that. I don't think any one person knows the answer to that. But I do think that it's the healthcare workers who work in that system and live in it every day and face the challenges who probably have the best idea and are best equipped to think of innovations for how to fix that problem. So the approach we're taking with health system strengthening is actually a new quality improvement approach, where instead of saying like, oh, I have these great ideas for how to strengthen the healthcare system, we are organizing training and support and mentoring for quality improvement, and creating quality improvement knowledge and teams among the healthcare system in Busia, and then providing mentoring and support so that each healthcare facility can run their own quality improvement projects and see the changes they want to see happen in the healthcare system come to life. And right now we're still in the primary planning phases of that, but we've launched with a pharmacy quality improvement group. And that's what I was mentioning. I don't, those of you who were on the call earlier, sometimes being in the US, I've been waking up at 3 in the morning to have lectures on quality improvement, which is something I never thought I would do. but we are moving forward and it's going really well. And we've brought together stakeholders from across the county and sub-county, including KEMSA, which is our supply company for drugs and medical supplies, to really problem solve and figure out how do we fix this supply chain issue and how do we improve drug supplies. And so we hope after this pilot to sort of take lessons learned and expand it to other areas of healthcare in the county. All right, now we're ready for pillar 3. I did this wrong. I did it in reverse. Now we're ready back for pillar 1. See, I'm always confusing the pillars. I don't have the diagram in front of me. So pillar 1 is community-based economic empowerment. And this is really where we think about the social determinants of health with population health. And the idea behind this is to incrementally increase people's ability to make a stable income through basically table banking and loans. And Empath has trained people in the communities we work in finance and agribusiness. And these leaders go into the community and help form community groups that then get training on finance and microfinance and table banking and agribusiness like poultry and dairy keeping, and form their own community groups to save money and then loan money to one another, and then take on their own generally agricultural businesses in the areas we work, and use those businesses and their collective groups to reach larger markets and try to get a more sustainable income that way. Joe, did I get that right? You're more of the pillar 1 guy than
You're doing fine.
We used to sit in population health meetings and everyone would go around and say what pillar they were. And I didn't have a pillar for months. I would just sit there and be like, I don't have a pillar. So now I'm squarely on pillar 2. And I'm forgetting some of the things that I've learned about the other pillars. But basically the idea behind pillar 1 is that it provides a mechanism for communities and individuals to sustain their own income. And then that income allows them to pay for health insurance, pay for healthcare, and attain the other important things like access to stable housing and nutrition and education, and those things that are so vital to any amount of medical care that we do. And then I'll just mention also another component of pillar 1 that's sort of like a special example of these community groups is the trauma mother and baby groups. And these are special focused community groups for expectant mothers and new mothers who form social groups and provide social support to each other, and then also apply some of these savings and loan principles to provide a more economic situation for themselves and their babies. And I was going to say something else about them. Oh, and then also incorporated into these groups are special educational processes for pregnant mothers and new babies to help make sure that they get to the appointments they need and they get the prenatal care that they need. And these programs have been very, very successful in improving maternal and child health outcomes in our other counties. And we're very excited to be able to scale up the programs that are already happening in Busia County. All right, so we've covered all the 3 pillars, and I'm keeping an eye on time. I've probably talked too long already. I was just going to mention briefly the challenges that we're facing, in addition to the normal challenges that you face as a program. Of course, the new challenges are COVID, which none of us expected, and that has been an incredibly difficult situation for Busia County to deal with. It's been a major stress on the healthcare system to deal with this. Busia County is on a trucking route that runs from Nairobi to Uganda, and we have seen and are expecting a very large impact of COVID from truckers carrying the virus from the cities as they wait to cross into Uganda. And we're just seeing the start of it now, but it's going to be a major stress to the healthcare system, and really has put some of this big picture long-term work on hold as we try to support the county to meet their needs with COVID response, because that's what's most important right now. And then on top of COVID, which this one you probably don't know about, the Busia County has faced terrible flooding in the last 3 months. Deb, I don't know if you have that photo I sent you, but it's been the worst flooding in 60 years. They have, almost all of our clinics are flooded, and or where I think it's a little better from when this photo was taken a couple months ago. But many of our patients and our clinical officers have been displaced from their homes. They're staying in schools and shelters because they can't get to their homes. They've lost valuable documents, including their national identity cards, a lot of their personal belongings. And as you can imagine, this has been devastating to the economy of the county we work in, because of it's primarily agricultural, and I'm sure you can imagine the corn would not survive 4 feet of water. So on top of COVID, it's been a double hit to our patients and our clinical officers and everyone we work with. And again, our focus has really shifted to providing immediate support to what they need the last few months, which has been like food for these shelters and for the COVID care units and that sort of things. And it's been a major, major challenge that we're trying to figure out how to keep our long-term goal in mind and move it forward, yet also respond to these disasters that are happening one after another. All right, Joe, you're the best at providing very philosophical, profound, and optimistic statements. So I'm going to throw it back to you to leave us feeling good after these challenges.
I feel just fine. Actually, let me, people may have asked a few questions and we're just about out of time. Adrian, maybe you have some, as our moderator, you may have gathered a few questions that we could respond to.
Thanks, Joe and Caitrin. Thanks so much for that summary of the, the history and the future directions. And there are a number of comments and questions that people have. So one was maybe to both of you to comment on the challenge of mental illness that you see out there, and how Empath is responding to the problems of mental illness.
Caitrin, you want to do it, or I can?
Sorry, Adrian, you said, what was the first part of that?
Just the mental health effort.
Yeah, what do you see in terms of the challenges in mental health, and how is Empath responding to that?
Okay, sure. Yeah, mental health is a major, major challenge. Everything from substance use, particularly alcohol use, to depression and anxiety, all of the things we see here. And there's actually a large grant led by Edith Quoba on our Empath team that is starting community-based mental health programs for care and support, which has already been started in many of the other counties we work in, as well as actually building a entire rehabilitation facility next to Moy Teaching Referral Hospital. And we plan to incorporate her work into what we're doing with healthcare system strengthening in Busia County.
Joe, did you want to add anything, or?
No, it's so often left out. People talk about chronic diseases, but there's hardly anything has more devastation in the community than the problems of unattended mental health. And I'm really proud of the program that it's made mental health a key part of its approach to non-communicable chronic disease. It gets just as much attention as heart disease, hypertension, cancer, or whatever. We've got a lot to learn and how to do it, but it's extremely important.
So a few other questions. What's the process like for individuals to become a healthcare worker in Busia? So what kind of cadre of healthcare workers are you working with, Joe and Caitrin?
Well, I think I mentioned a number in the group. The linchpin is a clinical officer. For those not familiar, that's kind of like a physician assistant. And that's 4 years of training after high school. It's certified, and they can have a lot of responsibility, and they're the backbone of the care system. But nursing, we have social workers, nutritionists, and so forth. Of course, there's not a lot of jobs. If you have an opening for 1 or 2 people, you may have 75 applicants. You know, I mean, there are a lot of people trying to find work just because of a limited number of salaries available. But there's a lot of wonderful talent in Kenya if we can find the resources to hire them and sustain them. What do you want to say, Caitrin? You may.
No, nothing really to add. Most of the patients or most of the healthcare workers we work with are the clinical officers that Joe described, and they're incredible. They handle very complex HIV patients. They're incredibly talented, and usually when they bring me a case for a consult, I have no idea what to do. So they're very good.
There's a comment from a Moy University medical student up at 3 a.m. watching this who'd just like to thank everyone for your efforts. thank everyone.
Well, just let them know that we're depending on them to bail us out as they finish their education.
Question about one of the challenges we face in terms of the supply chain, particularly of family planning, but contraception, but really more broadly of all kinds of pharmaceuticals from KEMSA, and how the counties navigate that.
Well, that's a tough one. I think they do reasonably well with family planning supplies. Caitrin, I don't know. I've usually found that they had the injectables and the other things fairly faithfully. I don't know about recently, but there are always stockouts with other drugs. We are going to lick that. I won't go into the revolving fund pharmacy model that we've developed with the counties and even helping them with supply chain. But fundamental to doing this whole program is to solve the problem of supply chain and faithful access to the needed medication. There's no other way to sustain the loyalty of the community without solving that problem, and we have it as job one.
There's also a question about, do we have any artisan workshops for women in Busia as part of economic sustainability in Pillar 1?
There certainly are artisans there, but not like we've had with the Imani workshop, which evolved to different names now. But there are people who are artistic, but some of them are using those artistic skills to fix your hair, or beauty shops, or trying move into, I know Sakama, we made available sewing machines, started shops around that. But that's an area that's going to get much more organized, I hope, as Pillar 1 begins to spread its wings beyond just agribusiness. We've got to move into these areas because these people are tremendous artisans. It's amazing what they can do if they can get some guidance and support.
Great. So I'm conscious of the time. I don't want to keep everyone too late. It's 8 o'clock. So maybe we'll pause there and just thank you again, Joe and Caitrin, so much for sharing your experiences and what Ampath is up to in Busia County, and really many ways the future and the sustainability of our efforts in HIV, and just to thank everyone else for joining us today. I think this is really exciting. We're over 110 people.
Hello, can I say something really quick, like a minute?
Sure.
Okay, this is Nicholas Tanui. I'm currently in Columbus, Ohio. And I wanted to appreciate Joe Mamlin and Sarah Mamlin for everything they did in Kenya. I'm from Kenya myself, but currently I'm in the US. And I want to say, back in 2010, I was diagnosed with type 1 diabetes. It's something off the HIV chain you guys are talking about, but I felt like I want to say something. So diagnosed in 2010 for type 1 diabetes. And then in 2012, I was doing so bad in sugar management. And then one doctor, Dr. Kamano, she was running the home glucose monitoring program in Ampath, Eldoret. And she was like, I think I'll have to admit you to the home glucose monitoring. And then when I got there, I got the resources that I had not gotten in the past 2 years because I was doing so bad. I could not even jump because of the, I think, what do you call the nerve things, the nerve disease, where you cannot feel your nerves.
Neuropathy.
Yeah.
Yeah, neuropathy. Yeah, and then we met with one Sonak Pastakia and the Ampath team, and then they gave me the resources like patient education on diabetes, and then they gave me resources like free glucose monitoring strips, and they would call me like every Monday to take my readings and stuff. And so I was like kind of impressed and decided to volunteer for the home glucose team in Eldoret. And then, as they say, the rest is history. And I got hired by Ampath to work at a Webuye clinic for home glucose monitoring. And by then, I had gained a lot of experience in patient education. I was managing my sugar so well. And it changed my mind of thinking because I was from accounting background. And then in 2015, I got an opportunity to immigrate to the US through the lottery, the green card lottery. And then I was like, man, I need to be like Joe Mamlin and Sarah, where I can go back to Kenya and give back to the community by like raising the diabetes and treating those guys. But the only way was to be a practitioner. So I was like, how do I get in here? So I started as an LPN and I graduated last year. So this year I enrolled back to the associate degree program in nursing. And then I'm gonna keep on keeping on until I get my nursing practitioner. And then I'll ask Joe, how do we go back to Kenya to help those people with diabetes? The way he did for the HIV. And I'm like, I'm so grateful. I'm really grateful. And getting those test strips and free insulin is not a joke, because one vial of insulin costs about $15, but back there getting that $1 is a challenge. So Ampath really helped me, and I wish God would bless you guys so abundantly, so abundantly. I'm really appreciative, and I was like, even though this is another program, but it's still under the umbrella of Ampath of what I want to say to these guys. So keep up the good work, and hopefully in the next maybe 3 or 4 years, I will enroll to either Purdue or Indiana University to do my master's in nursing, and then I could go back there and do what Joe did. Thank you guys, and appreciate this time.
Nicholas, thank you so much for sharing that story, and we're so glad you're doing well. And there's a professor from IU Nursing School on the phone, so we'll be sure to connect you. Let us know. So again, thank you all for joining. I wanted to give Caitlin Bernard is going to be hosting our next one. We're going to be doing these monthly, so maybe give Caitlin just a minute to give us a little snippet of what's going to happen next month. Caitlin, you there?
Yeah, hi everyone. Julie, who is from University of Toronto, and some of our colleagues from Kenya are going to be joining us for a similar fireside chat to talk about some of the both initiatives that we've been working on in reproductive health in Kenya, and also some of the challenges that women and families have been facing uniquely during this time of COVID, including supply chain issues, stockouts, and really what effect that might have on long-term health for women facing, significant risks in pregnancy. So we appreciate all of your involvement and questions, and look forward to talking more.
Great. Thanks so much, Caitlin. And Caitlin is I should have introduced you better, but Caitlin's one of our OBGYNs here at IU, but has been involved with global health, and I think one of about 10 former team leaders on the call tonight. So anyway, we look forward to that next month. So again, thank you all so much for joining tonight. And I know there's a few more comments and questions that have come in. We'll follow up with you individually if you put things on there that we haven't addressed. So again, have a good evening and take care of yourselves. Mask up, everybody.
All right.
Bye-bye.